I'm Dr. Vel Murugan. I'm a consultant pediatric neurologist. The topic I'm going to do about is neurological issues in children with developmental delay. You might wonder why not just talk about developmental delay. What I'm really doing is to talk about the diagnostic component of trying to figure out what is going on with the child with the developmental delay and how to tease out that information. I'm not going to dwell much on the treatment options. Okay, right. So this is, you wonder why I put this slide on? So just to remind people that any answers? Why I put this slide on developmental delay and putting an elephant there? What's the elephant got to do with the developmental delay? So what you're seeing here is each one being assessed by the same criteria, and even among humans, there's a lot of differences that we need to consider depending on their genetic makeup or the environment in which they have been brought up. So we need to be more sensible about it, and that's what I'm really mentioning. And the Indian education system being unfair, this is how it is. And I was one of those lucky ones who got through. Right. So let's talk about what a neurologist would think about when they come across a child with developmental delay. So their line would be, is there an underlying diagnosis that I need to clarify? Are there any day-to-day problems and how do I manage that? What are the complications that can develop in the future and what needs monitoring? And genetics-wise, is this something that's got a genetic background that it can recur in the family, or getting a genetic diagnosis might be helpful as newer techniques and diagnostic methods and things come into play. Okay, so right, I'd let you read this for yourself. I'll give you a minute. A minute is too long. Right. See, many people would think this is what a neurologist does. So he finds out something and says it's fascinating and doesn't really do anything about it. And I'm going to tell you a little bit about what we really do. Okay, this is how other pediatricians feel about pediatric neurologists. Right. So when you look at the diagnosis, these are the questions which should come into your mind. Is there a static brain injury or is it a progressive one? Is it a metabolic disorder which needs to be treated? Is there a chromosomal disorder? Or is there a treatment which needs to be instituted and not missed? If you miss it, then the child's development is going to be affected quite significantly. Right. Let's look at the causes of developmental delay. The idea of looking at these causes is what happens at different stages. First one is antenatal. That's what I mean by that lady who's supposed to be pregnant in the pink skirt. So things that can happen during the pregnancy: trauma, bleed, and infection. These are things that you should always check about. PV bleeds, infection, and trauma. So all these three can contribute to a child having been damaged. So antenatal history is always very important. At the time of birth, was there asphyxia? And the typical way of finding that out is, was there a seizures within the first 24 hours? Say the seizures happen about 3 days or 4 days later, that's unlikely to be related to asphyxia. So asphyxial injuries usually cause seizures within the first 24 hours. And if someone is said not to cry, but they said, oh, he did not cry, but I was told he had asphyxia, very unlikely. that they wouldn't have seizures within the first 24 hours and then be unwell. So that is always something you need to clarify. Now, what kind of injuries that can happen to the brain in the early stages, in the neonatal period? Hypoglycemia is typically the most common one in India. And of course, you need to consider meningitis and any um, intracerebral or intraventricular or bleeds. Now, as they become children, they can have some head injuries, sometimes meningoencephalitis or intracranial bleeds. So all these can cause um, brain injury and affect the development. The idea I'm mentioning all these is these are all static brain injuries. So static brain injuries which you know about. Okay, right. Let's go into the next one. Metabolic. So the question comes up: is it metabolic, and how do we find out? So you need to look at all these points. So when there is a developmental delay and there is regression of milestones, think metabolic. If there's a significantly abnormal neurology, so for example, a child who's got low tone and has got very brisk reflexes, think carefully why it doesn't fit in. So when you have all these features together, you have to be concerned. So if there is a family history of someone else having a similar problem, or previously a child has died, if there is consanguinity, and sometimes a normal MRI is probably the most commonly it's the normal MR scan. It should also concern you about whether there's a metabolic process going on. If it is abnormal, you could also always look at whether this is fits into any of the patterns of fixed brain injury. So if there isn't a static brain injury, then you need to think about a metabolic cause. Seizures and movement disorders again can point to metabolic disorders. Now, can anyone um, tell me why do we really need to look at metabolic? Is there a reason why we even very risk diagnosis that be a metabolic disorder? Can anyone type, please? I might just stay on if you don't type. Hello? Can someone just type and say, why are we even querying metabolic disorders? Very basic stuff, guys. I'm glad someone asked that question. Why are we looking at metabolic disorders as a cause for? Why are we looking at metabolic disorders as a cause for the developmental delay? I've given you the situations when you need to look out for metabolic disorders. The question is why. You need to know why. Can anyone comment? I can't hear you guys, so please type in. I'll be able to see it. So none of you want to answer that question. I'll just move on then. Okay. Because there are a few conditions which are treatable. And if you treat them, the improvement can be quite dramatic. So examples are dopa-responsive dystonia, creatine deficiency disorders, cerebral folate deficiency, biotinidase deficiency, pyridoxine deficiency, and there are a few others as well, but of course we'll have to have the metabolic physicians in. Now, CP mimics. These are conditions where they look like children seem to have cerebral palsy, and you think, oh, this is static brain injury, cerebral palsy, and you look, while really they have a disorder which can be treated and the child can be made better. Okay? So amino acidureas, GLUT1 transporter deficiency. Anyone know about this? What is GLUT1 transporter deficiency? You can type in if you can. Fatty acid oxidation disorders, they can die suddenly. Creatine, again something which can be treated. Menkes and Wilson's again can be treated. Mitochondrial, we can only give a yes, glucose transporter. That's right, the transport of glucose from blood to the CSF. So you look at the ratio and it is less than 40%. Neurotransmitter disorders, of which some of them are treatable, and of course organic acidureas, UV cycle defects, and vitamins and factor deficiencies. All of these can look like cerebral palsy, and then you can be completely misled. So if someone comes in with a label of cerebral palsy, don't jump into the diagnosis that's been given. Please do think over and say, does it all fit in? And if you look at those aspects which I have gone through before, that will give you an idea, particularly antenatal history. When did the injury happen? What is the pattern of injury you are seeing on the scan? And is there family history, consanguinity? Is there any regression? All those things will just give you that details. Particularly a normal MR scan is going to be helpful. Okay, so when to suspect it? If the MR scan doesn't show the relevant brain injury. So someone walks like a child with hemiplegia and they don't have an MR scan changes related to that on there. So that should make you suspicious. So a child who walks as if he has a hemiplegia and has a MR scan which is completely normal, you have to suspect metabolic disorder. Most likely to be mitochondrial in that instance. Substantial seizures where you have only white matter injury. That would again make you suspicious. Then no history suggestive of the relevant brain injury at all, but there has been a brain injury. Then you need to really look at whether there's a progress. What are the tests that you should be doing? So first line. So the idea is when you do these first line tests, you'll probably get about 57% of the answers when it is a metabolic disorder. So acyl carnitine, plasma amino acids, copper ceruloplasmin, serum cholesterol, creatine metabolites, purine and pyrimidines, urine oligosaccharides, and urine organic and amino acids. So when you do these first line tests, they felt 57% of the metabolic disorders can be answered. So however, still for the developmental delay, chromosomal is the most likely cause, or the brain injuries, static brain injuries. The metabolic is much smaller, and of that, 57% can be answered in the first line of test. Again, these are not cheap. So other tests to be done: homocysteine, ceruloplasmin, lactate, ammonia, urate, acyl carnitine, and the urine amino organic acids, purine and pyrimidines, oligosaccharides and polysaccharides. Please ask any questions. Okay. I'm trying to do it as short as possible. Won't go more than 20-25 minutes. Next is the chromosomal disorders. When do you suspect chromosomal disorders? Usually children with chromosomal disorders have significant hypertonia. If someone has got hypertonia, chromosomal is very unlikely. Dysmorphic features. So that is again typical of chromosomal disorders. Now, one condition which can mimic is peroxisomal disorders. So if they have normal reflexes, normal power, the development is on the right trajectory but slow, the MR scan is normal, all these things put together with the hypotonia, you are suspecting chromosomal disorder. And of course, in this scenario, you should also consider muscle diseases. Again, most often you will have your muscles weak, but it doesn't have to be the case. Okay, so something to watch. Again, progressive. Is it progressive or not? It's a very difficult question to answer. So, because children with cerebral palsy can show a deterioration in motor function when they are growing. So, the muscles become a bit tighter and they can run into trouble. Someone was walking reasonably well, owing to their growth, the bone grows better than the muscles because the muscles are tight. Then there is a discrepancy, and the child starts walking up on their toes, and that affects their motor function significantly. Now, you might think it is progressive. It is not. Here, it is not a progressive injury, a progressive process. It is the injury process is the same, but as a child is growing, that is affecting what we are seeing. Any acute neurological deterioration, acidosis, new onset symptoms should always raise concern. And of course, they are developing epilepsy. You need to watch it. Can you make sense of this? Do you wonder why I have put this slide on? Just to impress on something, some message. Can anyone get it? Any of the five of you? Wonder what I'm trying to say? Can anyone type, please? Or just say, what is the problem with this diagnosis? What's the problem with this diagnosis? Is it a mental health problem for the koala bear? Phantom limb-like. Right. I'm going to disagree with that. What I'm trying to impress here is, thanks anyway for at least coming out and typing something. I'm not sure about the others. The important age students, excellent. What they have done, what we have done is we have all the trees, and the trees is the environment where the koala bear is going to be comfortable. So you've taken them out of the right environment and put them into a place where they can hardly get any leaves or food, and then you walk in and then they're shivering, and you say, oh, there's a mental health problem for this. So what I'm trying to say is environment is a very, very important one. This is really a joke, doctor. Yeah. But this is a joke. This is a cartoon I had copied. And the idea is to say, see, no one's going to point to a child and say he's got a mental health problem. What it is you might consider that there is a mental health problem, while really it is the environment which is causing the problem, and that environment could be from the family or at school or wherever. So it is the same thing. That's what we are mentioning. Okay. We don't mean this is a cartoon. This is supposed to be a joke. Right. What are the day-to-day problems that you're going to come across? Typical first one is epileptic seizures. So how would you manage that? So one of the best drugs really I like, although it is quite old, is carbamazepine. The typical main problem is sleepiness and rash. And if there is a rash, you will have to stop the medicine. You have to start at a very low dose. I usually start less than 5 milligrams per kilo per day and increase gradually every 2 weeks. Valproate can cause hair thinning, hunger, deterioration with Alpers. Alpers is a condition, mitochondrial disorder, where if you give Valproate, the children will deteriorate. Lamotrigine, you have to do it as a very, very slow titration, starting at 0.15 to 0.3 milligram per kilo per day, and then increase it every 2 weeks. And that is the only way to avoid the rash. These drug interacts minimally with others, and it also causes much less sleepiness. Quite an effective drug. I appreciate it a lot and I use it a lot. Levetiracetam is the most often used one. Behavior problems and rage is something I'm coming across on a regular basis. So epileptic seizures have to be treated because they by themselves can cause a significant developmental delay. So those are called epileptic encephalopathies when the seizures are so significant that it affects someone's development. So forced normalization. Has anyone heard of this term? So the epileptic seizures are controlled with your medication, and the child who has been quite docile and sleepy suddenly starts causing lots of trouble and causes havoc. Then the parents come along and say like, look, what have you done? What's happened to my child who used to be very quiet and now is causing so much of trouble? What you are really doing is you're controlling the epileptic seizures to such an extent the child has become quieter and the seizures have come under control, and then the inherent behaviors all come to the surface. Then always look for depression and any signs of abuse. What are the complications that can happen in children with developmental delay? These are things which you should always monitor. Okay. For example, scoliosis. So if a child starts really curving gradually, by the time they have become so worse, you might not even, if you are not looked for it, then you realize, by the time you realize it, this child can't be treated anymore, and this is something which can significantly reduce the survival in the child. Hip migration, you have to check it using a migration index, and this is again something which is preventative, because if you have to look for it and prevent it, if you don't, then the hip migrates and then you run into trouble. Excuse me, I'll just answer this call. Hello? Hello? Good evening. Who's calling? EG பண்ணிருக்கீங்களா? I'll be there next week. Yeah, 21st அன்னைக்கு எனக்கு வந்து EG மட்டும் அவங்கள்ட்ட கொடுத்து அனுப்பிடுங்க. ஆமாம், நான் வந்து அங்கே பார்த்து சாப்பிட்றேன். போட்டுருங்க. ஓகே ஓகே ஓகே, தேங்க்யூ. All came from the hospital, that's right. Sorry. So the migration index is very important in making sure the hip is not migrating, because if the hip migrates, unless you prevent it at an early stage, say by 2 years or 3 years, the hip will migrate fully out by about 9 or 10, and this child will be in a lot of pain. That's totally unnecessary. So any child who's not walking should have the hip monitored from 2 years of age. Children with chromosomal disorders are more at risk of tumors, so you should always watch out for those. And children with Down syndrome, for example, are prone to tumors, ALL and others, and they're also prone to atlantoaxial dislocation, and that is something you need to be careful about. And so suddenly a child who goes off his feet, you need to be careful, because they might have atlantoaxial dislocation and that child will just go into quadriparesis or suddenly die. This is how you calculate the migration index. You take an X-ray, proper AP view, and there are some guidelines of how the child should be positioned, the hip should be positioned, so that you get the migration index. And that migration index, if it is more than 30%, it's likely to need some intervention. While it is less than 30%, then you could probably do abduction splints and try to hold it in. Okay. Next, genetics. One of the main ideas is to be able to predict the future. So, for example, if you do a microarray and you find out this particular breakage, then you'll be able to say, okay, if this happens, these are the type of seizures that can happen, and this percentage of children who have developmental delay, and what can happen. Sometimes some conditions are prone to seizures, tumors and different things. So that will be helped. Genetics sometimes can clinch the diagnosis when you try everything else, it's not working. And you can also sometimes be able to predict the risk in further children. So that would help the parents go ahead with the next child or not. And that can usually be done within the around 6 weeks of age. And the new things is pharmacogenomics. Any idea? Anyone know what pharmacogenomics is? Of the 8 of you? What is pharmacogenomics? Can anyone comment, please? Please type. If you say something, I wouldn't be able to hear. No one's typing? Just make a guess. It's absolutely fine. I didn't know much about this either before, and all I know is for one line. But unless I ask you this question, you won't even think about it. If you don't think about it, it wouldn't matter to you what I'm saying. Study of genome, yeah, go on. You started on the line. Gene therapy, right? Okay. So, do you mean treatment with genes, or the genes of treatment? Do you get the difference between treatment with genes and genes of treatment? Absolutely, Dr. Shubham, that's perfect. So you can look at in the future, for example, a child comes in with seizures, you can look at them and you do the pharmacogenomics, and it will tell you which is going to be the right drug for that condition. So for example, you can say this child with carbamazepine will develop a rash, and then so you will probably have to use lamotrigine. So even that can be dictated. So pharmacogenomics tells you which drug is best. Excellent, that was very good. Summary. So you have to look at typical patterns of static brain injury. And if you have the typical patterns of static brain injury, like in cerebral palsy, then you don't have to investigate further. And the most common cause for chromosomal for developmental delay are the chromosomal disorders. Now, a normal MRI is not a waste of money because it tells you that there is something which could be treatable, maybe there. Okay, and the most important thing is once you made the diagnosis, you make sure that these complications don't develop. So the complications I mentioned is scoliosis, hip migration, yeah, contractures. Yeah. So this is the way a neurologist reasons. Not acceptable though. This is how they think. Now I'm going to give you some case scenarios, and you have to type in. If you don't type, I'm not moving in. I'll just probably close it then and there. Okay. So first one is a 10-year-old who has spastic diplegia and presents with a deterioration in gait. So you got a diagnosis of spastic diplegia, you got MR scan changes which are typical of that, and this child was been walking, and at 10 years of age we are seeing a deterioration in gait. Can you say this is not a progressive condition? So what do we need to do? There are no one straight answer. Every answer is right here. I really put it in such a way that progressive. Okay. Any other answers? Of the 8 people, only one person, Dr. Shubham, is answering. Can I get a response from any of the other 7, please? Please. The slide is on the on that now. So the question is clear. Is it progressive or not? So I've had one answer which just says progressive. Can I have another answer saying it is non-progressive, and why? Hello? All seven have decided to just put their hands away. Can't be bothered to type? Right. So both of them could be the right answer. Progressive, it can be non-progressive. So if it is progressive, you are looking at a metabolic disorder, sometimes like Huntington's can look like this, can present at that age. When can I say it's non-progressive? Particularly when this child is growing. So he's growing so rapidly that the bone is growing faster than the tight muscles. So in which case, the child develops contractures, the muscles look more tighter. Okay? And that might be the reason why the child's gait has deteriorated. You cannot reassure them, you need to do what is necessary to make sure the muscles are stretched. Okay? The case scenarios are going to be like that. And you will have to interact. If you don't interact, I am not going to move. So as a 3-year-old child with isolated speech delay, how would you investigate? Very simple question. I'm sure many of you would have come across this in clinics. I'm not able to see anyone typing there. MRI brain study. Right. Can you give me a reason why, please? Why would you do an MR scan on isolated speech delay? What are you looking for? Right, okay. Very unusual to find something of a brain injury there and then just have a isolated speech delay. My advice is when you have isolated speech delay, the only thing I'll do is a hearing test. And every other aspect is completely normal, socially, gross motor, fine motor, vision, and then I always check the hearing. Hearing is the primary thing to be looked at. If the hearing is not affected, then you just have to wait for the child to develop. And many of the times, just speech therapy would be enough. So I wouldn't really investigate much in detail when there is an isolated speech delay. Okay. Sorry, I jumped into case scenario 4. I should have been sleepy when I prepared this. So a 4-year-old child with global developmental delay, no birth asphyxia, got dystonia, brisk reflexes, and develops infantile spasms at 3 months of age. What would you do? Say the MR scan is normal. Can we do some thinking? What is human? Oh, UMN. Yeah, of course. UMN. So there is some problem with the brain, but the MR scan is normal. What's going on here? So I put in a slide before saying what we are looking for. Why looking for a condition is important, not a condition. The child with global delay has got significant dystonia, brisk reflexes, no birth asphyxia. Anyone keen to answer? I also added an MR scan is normal. No one. I hope you remember that I talked hypoglycemia induced. Usually unlikely to have a MR scan which is normal. It can, but the MR scan is usually normal. Not normal with the hypoglycemia. You have parieto-occipital cyst. Any other answers? This was in the slides which we had discussed before. So this would be a situation of a global delay where you have to investigate for metabolic disorders. Because this child has got significant dystonia, disc reflexes. Yes, absolutely. So, what you need to do is, I probably start with homocysteine, do a B12, because those two are easily treatable, and then get on with the urine amino and organic acids, and the acyl carnitine doing a tandem mass spectrometry, okay, and GCMS. So that would be the line to take, okay. And biotinidase is important because that is again something treatable. Now, 4 years and spasms at 3 months is pretty bad news. So, case scenario 5, a bright-faced 10-month-old baby who cannot sit. So, that means a child who is not even able to sit at 10 months, has no head control, is quite weak, and the deep tendon reflexes are absent. Can anyone give me the diagnosis here, please? Type it in, please. I can't hear you. Right, okay. Could you tell me why you think it could be cerebral palsy? It's not really ascending, it's static. Or this could be, I'm saying a bright faced. That means a child who's quite bright, looking around and smiling and looks quite aware. He's hypertonic, weak, cannot sit, no head control, 10 months of age, still no head control, no deep tendon reflexes at all. Where could the problem be? If you have absent deep tendon reflexes, where is the likely site? Right. You are getting that, but muscular dystrophy, you usually do have deep tendon reflexes. The weakness will be there. Angelman's, usually not to this extent because they won't have this much of weakness. And they won't have this bright face. The bright face, by which I mean typically someone who can smile well and looking around and very alert. And when you say that with weakness and absent deep tendon reflexes, always think of spinal muscular atrophy. Okay, but that's when you have absent deep tendon reflexes. Even muscle diseases, myopathies, you usually have some degree of reflexes. Okay. Last scenario, guys. I'll relieve you of all the stress. 10-month-old seizures, tonic seizures from day one, not responded to Gardinal, that is phenobarbital, levetiracetam, topiramate, and phenytoin. And this baby had increased fetal movements during pregnancy. Simply indicates that this baby was fitting while in the mom's womb. Okay? What would you consider? Any specific condition to consider? Can anyone type, please? Anand or Dr. Shubham, because none of the others, and another Dr. Raju. The other 5 have not bothered to step in at all. Any idea? When you have a situation like this, what would you consider? Would you try any medication? would you do any investigations? Metabolic can present on day 1. Yes, it can. See, this, yeah, yes, definitely it can. What I'm saying here is this child has been having these problems even before birth. That's what I'm indicating by saying increased fetal movements during pregnancy. So this is not just day 1 because the seizures have been happening even in the womb. What does that point to? It's in that pathway through. Anything you can think about which is more easily treatable? In these situations, please do consider pyridoxine. So pyridoxine dependent seizures can do this. So if you treat this child with pyridoxine, many of the seizures might just completely stop. So this is something to be kept in mind. Okay? Any questions? I told you how to go about the diagnosis in a child with developmental delay. And I put in a few scenarios. And now I'll come to the questions. Has anyone got any questions? We do have a few more minutes. It's gone nearly 40 minutes now. 40, 50 minutes nearly. So any questions, you can ask me now. This will be available, doctor, with Satish. So he should be able to give it to you. I think it will be available for you guys to look at. My previous PowerPoints have also been available to see. So is it too quick or? Right, okay. So I thought I put that slide in. When you go back, I said what is the first line of investigations to take? That would be the first line to take. Okay. So ideally what you could, this is article in Orphanet. My suggestion would be go for TMS, urine GCMS. So that would cover ACL, carnitine, plasma amino acids. Okay. So then you could probably do homocysteine and B12. And if there's a movement disorder, you use do kerloplasmin. Now, creatine metabolites, I would probably do it with the MR scan itself. You can look at MRS, and that would give you an idea if there's a creatine is really low. So urine organic amino acids will come in GCMS. Oligosaccharides, if you suspect any of those, what condition is that? Mucopolysaccharidosis. So those are the ones. And then purine and pyrimidines. So these are the kind of ones which are most commonly present with developmental delay. That's what they say. Okay. So 57% you will have the answers with this. And this is probably the best line to go for. Lactate and ammonia, depending on what it is. Because if the ammonia is raised, depending on how much it's raised, you can decide whether it is going to be an organic aciduria or if it is going to be really high, then it's a urea cycle defect. Urate is elevated, then you need to consider molybdenum cofactor deficiency, and of course purine and pyrimidine disorders. And in some of those disorders, urate will be reduced as well. Okay, so this is what I would probably advise as the first line.